Welcome to the Health Leader Forge, where today's health leaders help to forge the leaders of tomorrow. I'm your host, Mark Bonica, of the University of New Hampshire's Department of Health Management and Policy and the Northern New England Association of Healthcare Executives. Our website is healthleaderforge.org, where you can find information about subscribing to the podcast, links and information related to the episode, as well as our complete archives. Today's guest is Michael Peterson, the president of Androscoggin Valley Hospital in Berlin, New Hampshire. Androscoggin Valley Hospital is part of North Country Healthcare, a system of 4 critical access hospitals in the North Country of New Hampshire. In this podcast, I talk with Mike about his career, which includes 28 years of service to the Eastern Maine Health System, where he worked his way up from part-time work in college through being a licensed social worker, later moving into information systems, and then back to operations, to ultimately being the chief operating officer at Sebasticook Valley Health before coming to Androscoggin in 2015. I really enjoyed talking with Mike, and I think you will especially enjoy his insights about leadership and the experience of being a new hospital president. I have produced an extended version of the interview that covers Mike's career leading up to and including his work at Androscoggin, and an abridged version of the interview begins with his work at Androscoggin. You're listening to the extended version. If you'd like to listen to the abridged version, please check our website for the link. I hope you enjoy this podcast. Don't forget to leave us feedback on iTunes, Stitcher, SoundCloud, or wherever you might be accessing this recording. Also, I'm excited to announce that we are now getting the podcast transcribed thanks to a financial gift from the Northern New England Association of Healthcare Executives. Thanks for listening, and here is Mike Peterson. Welcome to the Forge, Mike.
Thank you very much. Pleasure to talk to you today.
You went to the University of Maine at Orono and studied public administration. Why did you choose to attend the University of Maine, and why did you study public administration?
My folks were both alumni of University of Maine, and actually had considered going out of state for college. I grew up in northern Maine, but after interviewing at a bunch of colleges, it was pretty clear to me that I wanted to stay in the state of Maine, and especially in New England if I could. And University of Maine, it was a natural fit with both folks being alumni. So. Public administration specifically, it struck my interest. There was at the time no healthcare administration undergraduate program. Public administration was basically the closest thing. Okay. It had a lot of similar curricula, so that's where I got into.
And you have family connection to healthcare. Your mom was a OB nurse and your father was a hospital CEO.
Yes.
Did that influence your interest in healthcare?
Absolutely. I actually tell this story at every job interview I've ever gone to. I was probably 13 or 14 years old when I first got exposed to the concept of healthcare administration, following my dad around the hospital and seeing how he interacted with folks. And realized that he was getting as much reward out of the interaction as they were, and vice versa. So it was meaningful work. It seemed like there was something important going on there. I knew he wasn't a doctor. I knew he wasn't a nurse, but I knew that healthcare was the industry I was going to get into. It struck a nerve that early in my life. So I thought I was going to be a clinician, and I used to ski in high school. And one day between races, I was skiing where I wasn't supposed to be and was out of bounds, ended up falling, breaking my back.
Oh, wow.
And actually I had to ski down the mountain
with a broken
back because they couldn't get get to me. But basically, because my dad was who he was, I got to see my own CT scan. As I went in for my CT, the tech said, "Do you want to see your images?" I said, "Sure." I popped around. And as I was looking at the slices coming up, I saw the bulging disc and the broken, the herniated disc and the broken lumbar, and I almost passed out looking at my own image. So it was pretty clear to me I was never going to make it through gross anatomy. So I had to kind of change gears a little bit and say, I'm not going to be a clinician. But healthcare obviously was still very interesting to me. I wanted to be in that industry, and I figured out that I really still could add value. Maybe I couldn't be someone who takes care of patients, but I could be someone who takes care of the people who do. And so that's why I stayed interested in healthcare moving along. It was from those early years. To a degree, that was a very big advantage for me because I had to focus. I always knew that was going to be my area of focus. When I got into college, it just clicked. I consumed every healthcare management kind of course there was at the time available, and it clicked. I found that it came naturally. It was fun to be a facilitator of problems and solutions. But what I found also was I like to solve problems not in a one-to-one relationship. I always like to see, okay, what other problems are on the periphery? What solution options are there that could maybe solve things that we hadn't even thought about? And the synergy, that naturally happens when you look at things kind of globally as opposed to a one-to-one relationship. And did that all the way through my undergraduate degree. As a matter of fact, I was taking grad level courses in MHA programs out of other colleges that had an arrangement with the University of Maine, just because there wasn't anything else to offer there in the public administration. But I knew I didn't want to be a city manager either. So
which is kind of the public administration side.
That's right. And a lot of similarities, strategic planning, capital planning, communications, and so forth. Budgeting is all, the basics, but I needed that specific healthcare related stuff. So went through the University of Maine at Augusta, picked up some courses and so forth, and basically graduated with my undergrad in public administration. From there, of course, went to Husson College, and they were just at the onset of trying to have an accredited MHA program, but at the time it didn't have enough accredited faculty to be an MHA, so I have a Master's of Science of Business with a focus in healthcare administration, which was great. I mean, it was.
So you went straight from undergrad to grad.
Yeah. Okay. While I was in the mindset, I was still working full time, of course, but in the mindset of studying and so forth, I just kept going. Got my master's right after my undergraduate.
All right. So your first job in healthcare was as a project manager for administrative services at Acadia Hospital in Bangor, Maine. How did you come to work at Acadia?
Well, actually, that wasn't my first job. That was just the first job that's listed on my current CV. It was too long. My first job in healthcare actually was in 1988. I was in plant operations at the Rustic Medical Center up in Presque Isle. Wow. I was doing everything from running conduit for electrical lines in the OB floor to pouring concrete for a pad of a satellite dish for the first telemedicine system in the hospital, painting lines on the pavement, mowing the grass, you name it. I was doing all kinds of stuff in plant operations.
Wow.
And it exposed me to basically every aspect of the hospital, which was really cool. It was doing that summers between, high school and college. From there, during college, I interned for a while at the Eastern Maine Medical Center in community relations, public relations. And then right after my undergrad graduation, I went to work for a subsidiary of the Acadia Hospital called Aspen Ledge. It was a adolescent teen housing unit for kids with behavioral issues. And that's how I got into Acadia. So between the Aspen Ledge and Acadia Hospital, actually I was in the Access Center at the Acadia Hospital, which was a 100-bed acute care behavioral and psych substance abuse facility.
Wow.
The Access Center was basically intake and registration. So I literally was taking phone calls from people at rock bottom, and helping them get into the hospital and get the services they need. And I did that for a few years and realized, wow, this is not my gig. Yeah. This is over my head in terms of being able to do this hard job in terms of, and I have ultimate respect for people who can help take care of people at that point in their lives. It's really trying. Yeah. So did that for 3 years. Actually I got my LSW.
Oh, really?
Yeah, LSW2 for a while, just to kind of help.
Licensed social worker.
Right. But wasn't my background, wasn't my education. I was still currently in school for healthcare administration, But so I needed a change. That's when I moved into administration and project management. And basically it's because in the department that we were working at the time, we were all paper-based. These are patients who were calling in before they were ever registered, so they didn't have a record. And so we had cabinets full of these intake forms, basically, that was just, taking up all kinds of space, and we were filing through stuff. This was back in 1992. So no EMR, none of that, so forth. So I pitched an idea to my boss at the time, and I said, I think we can do this better with a database. Why don't we, and she said, take some time, couple days, research what options there are, and make a proposal. Okay. So I did. And that led to a project that lasted about 6 or 8 months working with information technology at EMMC at the time. And it led to basically the first computerized pre-patient database for Acadia Hospital that was in use for many, many years.
Did you get something off the shelf, or did you build it?
No, we built it from scratch.
Oh, wow.
And so basically I did the research and worked with IT, and we designed and built it with the staff and figured out how to make it work, and we implemented it. And that was my first exposure to any IT in healthcare.
Yeah, because I wanted to ask you about how did you make that jump?
I'll get there. Yeah.
Okay.
It's an interesting track. So anyway, after that was rolled out, the administration was impressed enough saying, here's a guy that started from scratch with an idea, a concept, and went all through project execution. We could use some project management help. So I was tapped by the COO at the time and said, would you like to come work for us? We are working on developing out the hospital's department structure. It was a brand new hospital, remember, in 1992, Acadia Hospital opened, and it was from scratch. So I was kind of on the ground floor. And so at that time, I then had a matrix reporting relationship as a result of that project and working with IT. So I went to work for the Acadia COO and the system CIO at the time. So that was my first exposure to matrix reporting as well.
Okay.
And it was great. I was effectively the department head of the first ever IT department at Acadia. Got to write policies from scratch, hired the staff from scratch, and then was also tapped to do some, special projects for administration at the behest of the COO. So it was really interesting. It was, never the same day twice, and that's really all I look for in a job, is never a dull moment and never the same day twice. So that got me exposed to IT and started me working down that track as well. A few years later, we had a big date looming, which was Y2K.
Right.
And so a CIO at the time said, would you like to manage that project for the entire system? Sure, I'm not going to turn that down. So 1998, I moved on to up to the corporate level and started working for the system as the Y2K project director.
So you moved from Acadia to Eastern Maine Health Systems?
Correct. So at the time it was Eastern Maine Healthcare. It wasn't systems yet, but yes.
How big was it at the time?
There were 15 business units at the time, probably about 6,000 plus employees, representing three tertiary hospitals, a couple of smaller hospitals, for-profit arm, and 2 nursing homes, or skilled nursing facilities, at the time. But 15 different business units.
Wow.
At that time.
And so you were working on policy that affected all of those?
Well, I was working on that project, Y2K, that all of those boards representative were my bosses, effectively, working with the CIO. So that was my first exposure to a system and the multiple organizations within a system, which was really intriguing, because I really enjoyed starting to get to know and recognize the difference between each business unit, the hospitals versus the skilled nursing facilities versus the for-profit arm, the pharmacy and collections and warehouse and so forth, and the culture and the agenda, the vision behind each one of them. It's intriguing that how different they were, but how similar in some.
Even though they were all part of
Eastern system, Maine. Yet multiple member organizations, different cultures. Mm-hmm. But what was really great about that was the natural synergy that happens when you bring different people to the table to solve or work on the same problem. The ideas are amazing, and how one organization can actually be looking out for another when we're all working together. And so that was my first exposure to the value of synergy, bringing systems together. And I never forgot that. I'll get back to that later. So Y2K, though, was a pretty big project. I mean, $8 million budget, 400 plus people at peak, with managing that project. But it was a anticlimactic kind of result. I spent New Year's Eve, 1999, in a conference room with some sparkling apple cider, waiting for the things that we knew that were going to happen. And then the next few hours, waking hours, doing some interviews and so forth with local TV stations, because it was all over and nobody died,
Right.
And it was a dead-end job by definition.
By morning.
Well, a few months of cleanup for documentation to get the legal stuff taken care of and archiving information, but pretty much.
But the lights didn't go out. out, so everything was good.
No, everything was good.
So very briefly,
Sure.
for listeners who maybe were small children at the time that this happened, what was Y2K? What was the concern?
Oh, sure. Well, there was a tactic used in early days of coding to save lines, save space by abbreviating the year field in most programs we found from 1970, for example, just down to 2 digits, 70. And so we had to go back into all of these fields when it turned to 2000. Instead of the computer programmer or software, whatever the application might be, thinking it is 1900, it was actually 2000. So a lot of software companies or vendors chose to mitigate the problem different ways. Some expanded their fields, to 4 digits and put in a conversion table that says anything prior to 1939 would become a 20 something at that time, so 2000, 2001. Anything since would remain as a 19, like 40.
Yeah.
So that was one style. Another was they basically just said, no, everything 2 digits is going to be 2000 something. And then others decided, you know what, our code's too difficult, this is too big, we're just getting out. We're selling the business, or we're just going to end. So there were some vendors that said, as of December 31st, January 1999, we're done.
Yeah.
You better be on a new platform, a new software, a new application by then. So it was 2 years worth of work. And
so you had to look at all the systems in the hospital and try to figure out.
We created the very first, at the time for our system anyway, very first complete inventory of all systems, all vendors, all applications. I mean, it just had never been done before. And then had to do a very robust, investigation with every single one of them on high priority, what's going to affect a patient care or what a failure of this could do. It forced us actually, when they're still using it today, many hospitals are, to do contingency planning based on scenarios. There's no possible way you could plan for everything. So you think about, okay, what happens if the water goes out for any reason? And so what do you do? So we had, libraries of contingency plans built that were tested, sometimes just a tabletop discussion of what ifs, to all the way to doing drills. Okay, shut off the water. What do? We call in the city with a tanker truck. Do you plug it into the fire system? You name it. We ran all these scenarios. It was a lot of work to get ready for basically what we've benefited now is disaster drills.
Right.
So Y2K effectively was a great way to tee up disaster planning.
Oh, interesting.
And that's how we've kind of leveraged, the lessons learned that night. And often a lot of people say, well, okay, so, a lot of work for nothing. And I said, no, I think it's the other way. It was a lot of nothing because of the work.
Right.
We did a lot of planning. And there were systems that we knew would fail, but the vendors had said, well, here's the fix. It's gonna fail. You just go into the code and change the date setting after the failure and you'll be fine. So there was some work to do the night of, but those were fewer and farther between. The vast majority of the things, so it went from 99 to 00. It didn't affect the application or the function at all. It didn't affect the delivery of care at all. We just knew it was okay. Yeah. So a lot of time spent putting Y2K approved stickers on things and so forth. But you had to check, heaven forbid. The lawyers were coming out of school going, okay, we're going to get everybody. And it's nothing against the lawyers. Nobody knew what was going to happen. We just didn't want to put anybody in harm's way. Yeah. So we had to go through the due diligence.
What was it like managing such a big project relatively early in your career?
Yeah.
You had 400 people. And
it was intriguing. I mean, I didn't manage 400 people on my own. I had a team.
Obviously, right.
And every business unit had point people and so forth, and they reported to their local administration and boards and so forth. So it was really about facilitation. Mm-hmm. And I guess that was the lesson I learned, was the value in not doing everything yourself, but using others and facilitating getting things done, but also though being accountable for making sure things were getting done. So it was a great experience, a great education for me, especially in project management. I mean, it was a huge immersion kind of project management education experience, real world. This is a big project, but I did also learn the value of deadlines. When there's an absolute non-negotiable deadline, things change a little bit in terms of negotiating money or quality. Quality was non-negotiable. We had to deliver. It made pitching for budget fairly easy. You couldn't extend the timeline. We can't kick this down the road a year. So there's some value in it. It was coming, and we knew when it was coming. So we had a very clear, critical path of milestone checkoff dates. And are we ahead, behind? Allocation of resources was, relatively speaking, a little easier when there were absolute deadlines looming. So
you started at Acadia in a Eastern Maine healthcare at the time?
Eastern Maine Healthcare Hospital.
So you started at Acadia in an Eastern Maine healthcare system facility. You moved up to the corporate level, and then after you finished with the Y2K project, you went on to Eastern Maine Medical Center, which is also a Eastern Maine healthcare
Actually,
system.
Eastern Maine Medical Center was where EMH was born. I mean, the Acadia Hospital used to be a wing of EMMC, and the behavioral health wing. It just got too big, so that creation of that hospital was the genesis for EMH at the time. So it was the first hospital, still is the flagship hospital of the system. So
how did Eastern Maine Healthcare, now Eastern Maine Health System, kind of come about? Why did it evolve as a system?
It was really because of that. I mean, now there were multiple hospitals that were being supported, and the vision there was to be more of a utility or service support structure for multiple hospitals. So it was the brainchild of a gentleman named Bob Brandow, who at the time was the CEO of EMMC, and they worked together to develop the support network for these two hospitals. Initially, I think there were only 3 employees at the system. I mean, it was really about being a support service to these two hospitals. From there, though, it became a vehicle for supporting other subsidiaries and affiliates and so forth because of the economies of scale, the opportunities that has for negotiating contracts and so forth with vendors, suppliers, payers, you name it. I mean, kind of the standard low-hanging fruit. It's evolved since then, of course, as far as what its intent is.
So you went to Eastern Maine Medical Center, and you were the Director of Surgical and Imaging Systems.
Correct.
Now this is a operational role, so you left IT and went into an operational role. How was that change for you?
Well, it was kind of the path I was hoping to look for. Again, I had always kind of envisioned, how do I get from point A to point B? Point B being a senior executive or CEO president of a healthcare organization. So I knew that IT is very interesting, and it exposed me to all of the departments of the hospital, but I needed to get some operational experience in clinical areas. So I had, of course, performed work through the Y2K project, these departments, and at the time the patient care administrator tapped me on the shoulder and said, I know your job's coming to an end here. I think we've got some roles for you. I had just completed my master's program at that time, and I really enjoyed the mentoring, the teaching component of like the project work that we had at Husson. A lot of the work we did in our master's program was team-oriented in projects and learning from your colleagues as well as teaching your colleagues. My fellow students and we got as much out of each other as we did from the faculty, and that's as designed. So it was a great opportunity for me to practice my newfound skills or newly minted degree by helping to mentor the clinical nurse department heads of these departments into some of the basics on how to read a responsibility report, how to prepare a budget, how to report on variances and so forth. Some of the basic business skills that they just don't teach in nursing school, but these are department leaders who now have to do that. So this patient care administrator, his name was Fen Dickinson, had the vision of saying, well, here's a guy who knows business, who's interested in operations, who can help maybe mentor these folks. And so that was part of my role. I got to work with 6 different nursing department leaders, all those clinical departments, and part of my job was to help teach them business and financial acumen, some basic healthcare administration stuff, because I'm just coming out of school. So it was great exercise for me. It also exposed me to working with them the clinical service line department management. So that was my first
How is that different?
Direct. You're dealing with different things. Of course, the clinicians themselves. Many of these are, specialties or certification requires and so forth. So all the rules and regs that go along with that. The individual personalities. That was my first exposure to managing providers, physicians. I had a neurology group, and so that was, those were new for me. And I had been responsible for projects and support departments up to that point, but never profit and loss departments. That was new too. Okay, you've got revenue to report as well as now the expense management, and it was really about margin management. So there was a lot of
So now you're not just asking for money, you're having to
produce the money and become self-sustaining or better, ideally.
Right, preferably.
And then, so that was a great exposure there. I mean, that's, of course, I needed that background. But I think the biggest thing I took away from that was how much value I got intrinsically out of helping others learn this stuff. It was great when I could see this, seasoned nurse leader who had been an amazing clinician all her life and now was dealing with the nursing staff and LNAs or CNAs and so forth wonderfully, but really didn't understand some of the basic business acumen, and to watch her just get it, and thrive from there was really cool. I was proud of these people who were sometimes 20 years my senior, learning from me and me helping to contribute into their advancement in their own career and thus the department and the organization. That was really cool. That's why I kept getting up in the morning. It was a tough job then too, but I was in my 20s and working with these major departments in a tertiary care medical center. I mean, EMMC is a 426 bed medical center and a lot of responsibility. So I never,
especially for someone so young.
Yeah, it did teach me a lot of humility. I mean, I was humble being given that much responsibility, but I got a lot of good feedback from the nurses. They were gracious. They were grateful as well. And many of them said, nobody ever taught me this. So it was a lot of fun. I really enjoyed it.
There's often conflict between administration, nursing, and then medical staff, physicians. So how did you run into that, and how did you overcome that?
That's a good observation. Many times it's folks thinking, okay, well, I'm clinical, I'm not clerical, and so the administration piece is just, don't bother me with that stuff, let me take care of the patients. Absolutely, I agree, I respect that. And frankly, I know I can't do that. So great, let me do everything I possibly can to enable you to do that effectively. However, the reality is as well, we do need to take care of some of those things, or we can't keep taking care of patients. We need to keep the doors open. We need to keep investing in technology or resources or people or whatever it is to keep being able to deliver the mission. So some of the stuff is a necessary evil, if you will. But the way I bridge that gap, honestly, is just by listening and having conversations about, okay, what is it that you don't understand, or what are you resisting? Where's the rub here? And so through conversations with folks, got them to understand maybe my perspective, I learned their perspective, and we came to a place where we could, come together with either a path forward or a solution, idea, whatever, that served us both. And frankly, I didn't categorize it as clerical, clinical, administrative, or clinical function. It was just, we're running the department.
Right.
How can we best do that for the patients? And so that's really how I kind of led in with now I'd log in differently with different audiences, speak to nursing leadership or nurses differently than you do to medical staff and so forth, CFOs. I mean, you just got to understand your audience. So I'd adapt the message a little bit, but most of the time not most of the time, all of the time, I've found if you keep the patient at the center, it's hard to argue. You just change the context around a little bit, or content around. Context is always patient first. You're going to be good.
So you did that role for about 2 years, and then you went back to
corporate,
to Eastern Maine Health Care, or
at that time it was EMHS.
Okay, and it evolved to EMHS to be the director of e-business. So back into the IT IM kind of role. What was e-business?
Good question. It's a little misleading too, because yes, it had IT IM components, but it was kind of a marriage between that and actually, at the time, there was this kind of fledgling possibility for healthcare, which honestly is still evolving today, with this idea of personal health records. and actually moving the EMR out into patients' hands. So e-health was just starting. So e-business was really meant to kind of bridge the gap between IS, finance, marketing, and the actual clinical, the record, HIM, if you will, or the EMR, with, again, the patient at the center. So I had enough experience in all of those areas at the time that the VP of Business Development Marketing for the system approached me and said, hey, look, we've got this wild idea. We want to get into e-health. Would you lead it? And so there was no e-business department. There was no e-health department again. I always liked the idea of, if you can write your own job description, go for it. So I said, it was just one of those opportunities I couldn't pass up. I also missed, to a degree, working with the multiple business units, multiple organizations. That's another reason I was attracted back to corporate. EMMC had a culture. Everybody else had a different culture and so forth, and I really liked bridging between them and seeing the values and grabbing the great ideas from one or another. It was a little homogeneous for me at EMMC. I really liked working with a multiple organizations. So it was an opportunity to do both.
Wow.
So I did, and we actually became the first integrated health delivery network in the country to roll out an e-health product, a personal health record, back in 2003, I want to say. Winona, Minnesota had gone first, but they were just a single entity. We rolled it out for multiple hospitals across the system, first in the country.
So what could you do with that as a patient, as a member?
That was the first patient messaging system, secure patient messaging between them and their providers, scheduling appointments, asking for refills, the first, place to keep track of all your immunizations, allergies, and so forth. But it was probably an idea about 10 years ahead of its time. And actually, we talked a little bit about that. At the time I was serving as the national user president of IQ Health, which was Cerner's e-health product. And we talked about this, this is pretty progressive and not a lot of people are adopting it, and how do you get the physicians bought in that this is just one more distraction for them, and despite the fact that you could save enough money in stamps to pay for the system, it was difficult to get adoption. At the time, we actually never made our target of 5,000 registrants. So ultimately, it folded. We under-resourced it, in my opinion, but it was also a little bit ahead of its time. PHRs now are coming back, and someday Google's going to solve that all for us, and we'll have everybody will have their eye record or whatever it is. But we were literally back then talking about eye prescriptions, here's an information prescription, read these 2 articles and call me in the morning kind of thing. But it was too early. But at the same time, I was developing out the e-business department, so the structure for managing these projects on the IT side and working between IT and finance to get them budgeted and paid for. It was really about building infrastructure at the parent level that's still in shape today. I mean, that was the advent of the first project management office for IT, started from the e-business department. So it was still a very worthwhile several years.
So you moved, you added some additional responsibilities in 2003, became the corporate director for information systems.
Correct.
How did that change? What accreted to your roles at that point?
Okay, well, that actually came about because at that time, the CIO, who I was working for, again, matrix between the CIO at the system and the VP of Marketing and Business Development at the system, said, we have another project. He was the same guy that Dev Culver, he's still in Maine at Health Infonet, said, we've got another project. It's pretty major. It's going to make Y2K look like a cakewalk. Are you in? I said, of course, Dev. I can't turn away from a challenge like that. We at the time had 7 tertiary hospitals or acute care hospitals on, I think it was 5 or 6 different clinical information systems, business systems. And said, we want to convert them all to one single platform. It was called the Together Project. And we did. So I was the project director for that project that brought all those hospitals to the same platform within 2 years.
Wow.
Pretty significant rollout, huge budget, lot of work that got done, and it was a great team effort to do that. But that's kind of where that evolved from. They just gave me the title of corporate director. After the Together project, it continued in, okay, now we've got, single standard structure, so we needed leadership at the corporate to help kind of facilitate the rollout of managing these systems ongoing. So all of the local IT directors then reported up through me to the parent. And so that's how we started managing the economies of scale and figuring out how to prioritize projects across the system and so forth. So again, it was a project-driven development of infrastructure as the system continued to evolve and grow.
So in 2006, you left Eastern Maine Health System to go to yet another affiliate, Sebastopol Valley Hospital in Pittsfield, Maine,
right,
where you spent the next 9 years in a series of positions culminating with being the chief operating officer.
Correct.
Where's Pittsfield, Maine, and what role does Sebastopol play in the community there?
Okay, well, Pittsfield is about 30 miles west on I-95 corridor from Bangor. Okay. So just the next closest small hospital to the corporate parent headquarters and Eastern Maine Medical Center in Bangor. SVH is a critical access hospital, 25-bed hospital, so it fills a very crucial need for the community, where it's a small community, and SVH is like many communities where the critical access hospitals are the largest employer in town. And it was actually created by a few families in Pittsfield back in the 60s who needed a place to have their women have their babies. And so families got together. Many of the families are still in town, very supportive of the community, of the hospital. And so it was a great environment to be going into first foray into the senior executive level, into a very supported hospital by the community. It was not going into a broken ship or anything like that.
Trying to turn it around.
It was under great leadership at the time. Actually, one of my mentors was the CEO at the time, and he had an opportunity for me. We were at a ACHE conference actually, and he says, I got an idea for you. We're getting big enough that at the time chief operating officer, her scope and scale was getting a little too large for what they really wanted to do. So the position I moved into at that time, VP of Clinical Services, was brand new.
Okay.
Again, one of those chances, write your own job description.
Yeah.
So basically I picked up all of the outpatient, ancillary, and diagnostic service departments, and she kept all nursing and the other departments, and between the two of us picked up, the operational role at the hospital. So
it was a big scope, maybe not necessarily, I'm not sure if it was more people necessarily than you had managed before, but it was a broader scope than what you had had.
And it was back to clinical. I mean, that's the thing, and that's the point I want to make here is as corporate director of IT, and I was one of 3 or 4 corporate directors because we had a little different roles, but the same title. I was kind of on a CIO track, and I had to make a decision. And actually the CIO at the time, we had a conversation. I'd won an award from John Glaser scholarships and so forth, became nominated for Ones to Watch in CIO magazine and so forth, 2005. And it was like shaping up, okay, am I going to be a CIO or am I going to be a CEO?
Right.
And so I kind of had to make a decision at that time. And I said, you know what, I feel like I'm getting a little bit too far, a little too disconnected from the patient care. I've lost a little of the fire in my belly, if you will. I need to get closer. I need to get back to clinical operations. So that's why I was intrigued about going to a member hospital and getting back into clinical operations so I could get back on, in my opinion, the CEO role. Okay. At the time they were talking, a lot of CIOs are becoming CEOs. Didn't pan out that way. It still hasn't.
Yeah.
They're a critical aspect of running an organization, and they should be one of the most depended upon advisors to a senior executive, absolutely. But they're not becoming CEOs, and that's ultimately, again, what I wanted to do since I was 13,
It's a very specialized
14.
skill set, right?
Yeah. So I took the opportunity when Jack May, at the time was the CEO at SVH, says, here's this new role we think you could be successful in. So I took the shot. Yeah. I was very pleased. It felt great. I was happy getting that much closer to the actual patient care delivery. Again, I could never stand the guts and gore myself, but hey, being able to provide the phlebotomist the resources they need to draw the blood well, or provide the surgeon the tools they need to do that laparoscopic procedure. I mean, that's what I could do. As I felt like back in college, facilitating problems and solutions. So,
what does it? So you have all these different operations. Obviously, you can't become an expert in each of them.
Correct.
Which would kind of be ideal,
Correct.
To lead, but obviously that's just not possible.
Right.
So how did that affect your leadership style? What did you have to learn to do?
Well, what I learned to do is execute the old adage of, I think it was Confucius actually, and I apologize for the cliche here, but the wiser man has more questions than answers. I learned how to ask the right questions. I learned how to ask the right people, okay, tell me enough so that I can be helpful, and draw out of the experts, what it is they needed, what their ideas were, what their recommendations. Let's think through the impact. Let's think about an exit strategy. Let's think about all the possible options, and then together make the best decisions. That's facilitation of a solution, not determination of a solution.
Okay.
And that's what I really learned to do well. I had to do that, though, in IT long before, because I wasn't an IT geek. I was not a guru of, coding, but I knew enough to know how to ask the right questions of the people who did know the detail,
right,
so that we got the best answers. And from a leadership perspective, what that taught me was the far more valuable or beneficial way in terms of truly meeting full potential is collaborative decision making versus directorial or top-down decision making.
Let me ask you to extend that a little bit.
Sure.
Because most of the time, the people working for you are great, but sometimes you've got a problem in there, and without being an expert in the area. How would you detect it?
That's why metrics are important.
Okay.
Predetermined. Okay, how are we gonna measure success? What's the pace we should be hitting, the run rate for these milestones, goals, whatever it is? Getting agreement up front and then vetting them with other experts. We had a system I could lean back to, turn around to another VP of clinical services or ancillary support and say, what are you guys doing? I mean, how do you know when you can wave the flag of success? Well, and so you learn from other people.
Okay.
Work with the experts locally and say, okay, does this sound reasonable? Or if we wanted to get here, what would it take? And so let's line up the resources, put them in place, and then we should start to see this progress. I didn't need to know the detail or be an expert. All I needed to know was how to keep people on track, hold them accountable, respectfully, of course, but give them the tools and resources they needed to reach their potential. And then it just kind of fell out from there. Now, I've always been an inquisitive soul, so I like to ask a lot of those kinds of questions because I want to understand. And I pick that stuff up and retain it. I can still tell you how long it takes to thaw out frozen plasma because we ran into a problem one day in the lab and asked the question, so how much time do you need? I remember. So now I remember that as I'm talking about, okay, well, if we're going to be getting our plasma from over here, well, we better be within 35 minutes. So Those are the things that it just sticks with me. But really, it's about making sure you have agreement with the experts about what you're going to be measuring and how, what's reasonable, what's the aspirational goals maybe, and then just measure. It's the discipline of accountability.
You were on the senior executive team.
Yes.
What additional responsibilities were implied by that role?
Well, of course, I had to staff some board committees and help out with I was given the opportunity to help develop and manage the strategic plan, facilitation of the strategic planning for the organization for the last 6 or 7 years. So that was inherently, I had that responsibility. A lot of reporting to not only the local CEO, but the parent, and responsibility to system level task forces and either work groups or task force design, short term kind of thing, looking at something from a system level. And we did have that responsibility as member organization executives. We had a responsibility both to the local organization as well as the system. My personal philosophy with systems is strong members make a strong system and vice versa.
Okay.
So it's a shared responsibility.
One of the things you talked about when I reviewed your CV was that you were involved in these system level steering committees around lean.
Yes.
What is lean?
Lean.
Why is that important?
Oh, well, lean is important, honestly, because the nature of healthcare today, we have to continually drive down the costs. And lean is about doing that, just that. The relentless pursuit of the identification and elimination of waste in our processes. And frankly, healthcare is a target-rich environment for that. A lot of processes we do are truly non-value added. It's either they grew up over time and kind of grew up like a weed, sometimes you might hear it said, that really aren't adding a whole lot of value to the patients who would be willing to pay for it. You know, a lot, maybe there's some business value added steps, of course, registering a patient, billing, and so forth. We got to do that to run the business. But a vast majority of our processes are made up of some of those 8 deadly wastes that lean teaches. In a lot of inventory, we actually have rooms dedicated to waste. They're called waiting rooms. And so it's a kind of a unique take on transfer of manufacturing techniques and tools. Actually originated in Japan after World War II, Toyota production system, and actually was an American who went to Japan and introduced it to them, ironically enough, because nobody in America wanted to hear it after World War II. But it was slow to be adopted in the healthcare industry. It's only in the last dozen years or so that it's really become kind of the ingrained way of doing things, because we just need to drive cost out of the system. You know, the pressure from the payers and you know, the CMS and so forth, it's not going to change or stop. We have to get better at driving cost out without sacrificing quality. And that's really about the principles of lean. Quality is non-negotiable, and but we can improve processes to work smarter, not harder, as you've heard.
Right.
And lean is just a set of tools and techniques to do just that. But lean culture is different as well. Lean tools are everywhere, and some of them are intuitive. Some of them are literally a foreign language, so you've got to be aware of them and learn some of that discipline. But it's as much about having a lean philosophy in terms of being willing to let go of control sometimes from leadership, and say, you know what, the people who can solve these problems best for us are the people who work the process or the system every day. It's the staff, line staff. So we have to be comfortable and willing at the executive level to let go and admit we don't have all the answers, but let's engage the staff, and you can actually turn a group of employees into an army of people looking for problems to solve. And when that happens and you empower them to solve them, man, you can move mountains. So it's exciting work to me, because I love to see the progress, but I also love to see the staff get engaged and empowered to solve their own problems. And frankly, by doing that, we have a much better chance of solving them to the best of our ability than just applying a solution we think will be best, but we don't know the whole story. Or worse, somebody says, that's great. They don't know what they're talking about up there. We'll pretend we're going to do this and let's go back and do it our way. Or necessity is the mother of invention. They end up band-aiding or putting a workaround in place. Line staff in healthcare are the masters of workarounds. I mean, it's necessary because they have to take care of the patients. So it's really about harnessing that energy, applying some tools, and then supporting that culture to allow those tools to take root and really sustain improvement. So it's exciting to see more and more healthcare organizations adopting lean and moving forward with that, because it really can make transformational difference.
Is this something you've retained and
yeah,
continue to try to
absolutely.
use?
We're using lean here. I mean, one of the reasons I think I got this job was because of my experience in lean. They were interested in doing that for all these same reasons. Okay. But it's a discipline, and some of it's intuitive, and as I said, some of it is literally a foreign language. We have to be trained to do it and have the discipline, and then support it from the very top. Yeah. Otherwise, it's just another program du jour. But we can thank some innovators like Swedish Medical and Virginia Mason and so forth, who've kind of paved the way for healthcare to say lean can work in healthcare.
You were named Chief Operating Officer in 2013.
Correct.
What did that change in title represent for you in terms of the leadership structure at
Sebastopol
Valley Hospital and your role?
Well, at that time, the COO at that time became the CEO. and I was the CAO, which was relatively unique in New England. I mean, there weren't that many CAOs, Chief Administrative Officers. So before she became the CEO, we had a CAO and a COO. And again, for a small hospital, it's a little unique, but it was just titles. We both had operational responsibilities. When she became the CEO, I basically adopted some of the responsibilities she had, became a leader within a dyad model, working with the CMO at the time, the medical staff office, and picked up the responsibilities for the specialty surgeon practices and so forth, hospitalist and ED docs and so on. So basically I retained all my CAO responsibilities, plus that became COO, and we didn't backfill the COO other than with me.
Okay.
So it was just an expansion of role and responsibilities.
Okay. Well, so after 9 years at Sebasticook and almost 19 years with Eastern Maine Health System, you left
it's 28 if you go all the way back to 1988.
So let me back that up.
Or 29
so 28,
now.
29.
Yeah.
Well, yeah, because you started in high school.
88.
Right, so 88. Right after high school.
Yep.
So after 9 years at Sebasticook and 28 years, depending on how you count it, with Eastern Maine Health System, you left Maine and you came to Berlin, New Hampshire to be the president of Androscoggin Valley Hospital. So before we talk about your current role, can you tell us a little bit about Androscoggin Valley Hospital and about Berlin, New Hampshire?
Sure, absolutely. Well, Berlin is an interesting town, and of course it was a mill town up until very recently. It was the second largest city in New Hampshire. I mean, there was behind only Manchester.
Okay.
Yep, that was but when the mill closed and didn't come back, I mean, there was an exodus of people, honestly, because of the jobs. So it's, I believe, on its way back up. It kind of hit rock bottom, it's kind of plateaued, and now the economy is starting to come back. But it is your pretty typical small New England community. I mean, the values here are very similar to the values I've found and seen in small communities across northern New England. And honestly, that was one of the main attractants for me, because I did spend a little time in southern Florida while my wife was in grad school, and it taught me fairly clearly that nice place to visit, but I really fit in northern New England. Okay. It was really about the values, the sense of community, the sense of working together, but autonomy and independence and pride in accomplishment of things that I think is rooted in this part of the country. So Berlin's very similar to many small towns across northern New England, Maine, New Hampshire, and Vermont especially. It's 10,000 people roughly in town, but the greater Berlin area, if you think of Gorham and Jefferson, Randolph, and up towards Milan, Errol, as far as Errol, New Hampshire, we serve about 30,000 roughly people in this general vicinity. Androscoggin Valley Hospital is a 25-bed critical access hospital that actually, as you can see, is a little bigger physically than many critical access hospitals, because again, it was built here in the 70s when there was 30,000 people here in Berlin alone. So it was built originally as a 94-bed hospital.
Okay.
It gives us some definite advantages. There's some good space here that we can utilize, but we are still a critical access hospital. 20% of our book of business is inpatient, 80% roughly is outpatient services. We have a group of specialists, a lot of subspecialists you wouldn't expect to see in a small rural area, neurology, pulmonology, cardiology through collaboration with Catholic Medical Center, and a number of other subspecialists that, again, somewhat unique to critical access in small towns. But
how do you bring in all these specialists to a relatively small facility, yep, relatively small town? How do they build enough business to support themselves?
That's a great question. Part of it is having enough to warrant the expense, mm-hmm, and having the demand to warrant the capacity, if you will. So it's really about collaborating with, like, for example, the cardiologist we have here is through a collaboration with Catholic Medical. We've collaborated with other small hospitals that jointly together you have enough volume to support a full-time provider, because part-time providers aren't all that frequent, or it's hard to find them to begin with. They don't want to come work part-time. If you're just out of school and you're staring huge student loans in the face, do you want to work part-time? So it's really about having that critical mass. So collaboration is the name of the game for those things. And you have to. I mean, if we're working with Dartmouth for example, to help with our radiology program or lab, working with other small hospitals, you got to get to that tipping point, that critical mass. So collaboration is really how to do that.
Okay. And you have Valley Birthplace and Women's Services is one of your major product lines.
Yes.
Can you tell us a little bit about that?
That's our women's services line, OB and delivery, and it is now only one of 2 places in the North Country, northern New Hampshire, where women can have their babies. Incredibly important because, frankly, this is a huge geographic area. So we're very proud of that service. It's one of the leaders in the region. We do a great job. The staff up there are really compassionate folks, as are all the staff here, but especially up there, they love what they're doing, and it shows. So it's one of our best areas.
Roughly how many FTEs are employed here?
320 employees.
Okay.
And about 51 active medical staff, a little bit. We have a pretty good mix, too, of employed versus contract or independent medical staff, and it's worked out well.
So you are a member of North Country Healthcare, the newest integrated health delivery network in New Hampshire. When did this affiliation come about, and what was the genesis of that?
So it officially became a system on April 1st of this year. So it's brand spanking new still, but it was a brainchild of a couple of folks who are still now in administration of this system. Warren West and Russ Keene. Russ was my predecessor here as the CEO at ABH, and Warren was at Littleton Regional. And it's actually, the concept started a number of years ago, thinking about how we can better serve the population of the North Country by doing just that, working together, collaborating to find those critical mass opportunities for driving out cost and driving up quality. And that's really what any system exists for, is to do those 2 things. And frankly, it's, I believe, because of the realization that competition is counterproductive, especially with struggling economies, and everybody's fighting for their piece of the pie, if you will, that isn't getting any bigger really at this point. So collaboration is far more productive, far more cost effective, and it was about bringing them together with that vision of bringing 4 critical access hospitals to the table to help leverage economies of scale and share best practices across the North Country.
How did the system convince regulators that allowing those 4 critical access hospitals that are basically the sole providers in this area to work together, come together and not say, well, that's anti-competitive and we can't allow that?
I actually had to defer to Russ and Warren a little bit on that, but from my understanding, it wasn't easy.
Yeah.
We actually had to make agreements that for a period of time anyway, the system would not require the exit of any service line from any one of those given communities. So we had to make commitments to the AG that said, we are not intending to remove or take away any service line from any of these communities. The intent is truly to grow and enhance our ability to deliver specialty services close to home. But again, there's that angst and so forth, because I think everybody sees the writing on the wall. Duplication of services is not cost effective. We're about driving out costs. So does that mean we're going to have to travel across the valley or up to Colebrook or vice versa in order to get access to the services we need? Well, that's not the intent. But everybody kind of sees, okay, regionalization of service lines kind of makes sense intuitively. How are we going to make sure that we can continue to deliver the local missions without jeopardizing, or becoming too overburdened in terms of cost? So that was one thing I know we had to do with the AG before we got the blessing to move forward, was to make a commitment that we're going to study the opportunities and study the right models and so forth in northern New Hampshire, but we will not remove specific service lines for a specific set of time. And so that was, I think, what got us over the hump. We got the blessing and moved forward.
That's just really interesting. I mean, typically when I think of a system, I think of something like Eastern Maine, where you've got an Eastern Maine Medical Center, big hospitals an anchor, and then small hospitals kind of orbiting around it. Whereas this is kind of a merger of equals.
It is very unique. I mean, honestly, that was one of the things that attracted to me to this role. I mean, I'm not a guy that moves around a lot. I mean, I may have moved around in my career, but it was always within the same system. I actually have lived in the Bangor area for the last 21 years. So to uproot my family and move to New Hampshire was a pretty risky undertaking for me. I needed to feel very comfortable with it. One of the attractants was this new system. This was a system, as you said, of equals, 4 critical access hospitals coming together to try and achieve something. There is no 800-pound gorilla here.
Right.
You know, it's not somebody saying, okay, you will practice the way we do it because it's the way we do it. It's an opportunity for the 4 hospitals to come together and say, okay, we're all critical access hospitals, so we're all speaking the same language. I mean, there really is a difference between critical access and PPS, or the prospective payment hospitals. And sometimes things get lost in translation. Well, why do you do it that way? Well, we've got a cost report we need to worry about, so that's why we kind of look at things a little differently. That lack of awareness or understanding wasn't even an issue. We'd all been living it. The other attractive part, I'll be honest with you, is I'm the first of the new presidents. So right out of the gate, I'm going to have tenure, if you will, over the new presidents who are now being hired. When we come together to solve problems as a system, there's no baggage. You know, I will not have had worked with these folks in the past as competitors and, you know, be carrying this memory from years ago. Well, yeah, you kind of slighted me on that deal 2 years ago, right. So no, we're starting from scratch. So all that learning curve, if you will, is a non-issue. We will get to collaborate and work from this point forward, which is great, and it's a real advantage, I think. But just knowing that there isn't a 800-pound gorilla kind of out there, even if it's not, because I know I've worked at those and I've been at the system and watched it. That's not the intent. That's not where people's, there's no malicious effort to do that. But the perception, however, is, oh, well, they're so arrogant. They're just imposing their means of practice on me. And if I wanted to go work and practice in, like they do in Burlington or Lebanon or, Bangor or wherever, Boston, then I would have moved there. Let me practice way. No, it's really about best practices, sharing the best practice, and those can come from anywhere, including 4 small hospitals.
Yeah.
So it was really somewhat unique in the country, I believe, of 4 similar-sized hospitals coming together like this.
Yeah. I was wondering if it is maybe the only one, or I don't know.
I don't know.
Okay.
It's certainly the only one in New Hampshire, and it's the only one I've ever seen. A system, usually they evolve the way you've described. A large tertiary care center kind of being the hub of a hub and spoke model, and it all kind of feeds to that. This is 4 hospitals coming together to better serve the population of the area we cover.
So I wanted to ask about governance.
Yes.
So now that Androscoggin is a member of the North Country system, traditionally the president reports to a local board. What is your reporting structure?
So back into matrix reporting. I am responsible to the local board. So I have a board chair and the board committees and the full board as traditional structured. But there's also a parent board that the local board actually reports up to in terms of ratifying our strategic plan and our budget. So that's pretty traditional with system board governance structure as well. But personally, I also report directly to the system CEO, which is Warren West. So I've got my boss, quote unquote, the board and at AVH, and my boss, Warren West, the system CEO. And so it's really making sure that all the things we're doing are in line with the best interests of both the member organization and the parent, the system, as much as possible. Now, sometimes there will be conflict in those things, so we have to work those through. But ultimately, I do have a dual reporting line, if you will.
How does someone come to be on the AVH board?
Well, they are nominated by a nominating committee made up of the current board members based on need. We're actually going through a governance optimization project right now, as it were, identifying a matrix of skill sets, representation, geographic representation, and so forth of the makeup of our current board. And we identify members of the community who have the capacity, interest in doing so, reach out to them, vet them through the nominating committee. They get ratified by our local board first. New board members, that is, also have to be ordained, if you will, by the parent board to sit on the local board.
So you're looking for geographic representation.
Yes.
So you want somebody from Gorham and somebody from Berlin. And the
as wide as we can,
right,
for our primary and sometimes our secondary service area. Yes.
What else are you looking for aside from geographic?
Well, it depends on really, honestly, in an ideal setting, you'd want a good cross-section of skills or interests based on what the hospital is actually going through at the time. You know, we don't have board term limits right now, but we want to keep fresh ideas coming. But for example, if we were getting into a major construction project, we might want to have somebody on the board who's got construction management experience, or if we've got a lot of things going on with contractor payer negotiations, we might want somebody well versed in the insurance industry or banking, legal, you name it. But we always want to have representation of the community, as wide and broad a demographic representation as we can get. Clinical, business, financial, legal, and so forth. But again, it's got to be a good cross-section of who they represent is our community.
Do some of your providers sit on your board?
Yes, we always have providers. The president of the medical staff by bylaw sits on the board, as well as we have a board member at large who is a physician. We currently don't have nursing on the board, but we're working on that as well, because it's always a good idea to have that clinical representation right at the board level.
How many board members do you have typically?
Well,
it probably fluctuates a little bit.
It does. From time to time we'll get a variation based on departures and so forth, but bylaws allow for anything. Get it right here. We've got new bylaws. I think 18 is the maximum. I think 12 is the minimum. But honestly, you want a good enough number so that we can do a lot of work through committees. And so we don't want to overburden these. This is a volunteer position. These are people with day jobs, so we want to be sensitive to that. But right now we have 16 board members, and we're considering whether or not we're going to backfill the other 2 vacant positions to get to 18. Sometimes a smaller board is a little more nimble and efficient, but it's also, again, we want to spread the wealth and figure out, do we have all of the areas of interest represented? So we're going through that process right now with our own governance committee, evaluating, are we going to keep it at 16 or drop it to 14 or through attrition, or nominate and grow some more folks.
What's the work of the board? What do they actually do?
They are responsible ultimately for the quality of the care that we deliver. So that means they are responsible for making sure that the providers that we privilege and credential here will meet the needs of the community at the quality that the community expects. Ultimately, that is their job. They also have a responsibility to hire the chief executive and execute the policies to achieve the vision of the organization. In a nutshell, that's it. So they have entrusted me and my team to the responsibility of managing this community asset. And that's effectively, I work for them, nobody else in this building does, but they have empowered me to put into place organizational structure and policies and procedures and so forth to execute the vision of the organization, which is a collaborative definition with administration and the board.
Where does strategic planning happen in this organization?
Board level. Absolutely. Cool. This is something that, strategic planning will now also take place at system level as well, because strategic plan at a member organization has to support a system vision and strategic plan. This is a unique time for us. The system is so new. There is no system strategic plan, so we really don't have a current strategic plan for AVH. We have a working plan. We have a tactical plan just to stay on budget. We do have those things that we're trying to achieve for growth and service and quality and so forth. So that's an operational plan. A long-range strategic plan we'll get into next year. We do actually have a three-year working plan at the system that we're getting into strategic planning now. But in other systems I've worked in and member organizations and so forth, best strategic planning happens at the board level, but it happens with engagement by the medical staff, the community, including the patients we serve, the departmental leadership, and the line staff. Working administration, just facilitating all of that, calling out, okay, where do we want to go? How do we best cost effectively get there? How do we grow the quality? What's our standard going to be? And how do we keep pushing that standard higher? And that kind of fleshes out the strategic plan. I see myself as the facilitator, not the definition of that strategic plan.
So you report to the board as well as the CEO of the system.
Yes.
How do they evaluate you? What are they looking at Well,
very clear goals.
Mike, you did a good job. These are the things you did well.
Yeah. I've actually just yesterday reported the 6-month update status on the hospital goals to the board committee that's looking at that. There are 45 items that said this supports our work plan. This takes us to where we want to be to get ready for the long-term strategic plan. If we had a strategic plan, it would be the items on the operational plan that support the strategy. So it's very clear, very objective as well. How are we doing with the margin, service, quality metrics, people, turnover, retention, recruitment, blah, 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 engagement results and so forth. How are we doing in the community? Are we giving back? Are we supportive of volunteerism and so forth? There's very clear defined metrics. There have to be, because my departments have clear tactics and goals that will feed up to the hospital goals. So I'm measured based on the hospital's performance, based on those metrics. That's the objective part. Subjectively, it's about how are we doing building and nurturing relationships. And honestly, I believe that these roles are all about relationships. Nobody gets anything done on their own. We need each other and other people to get these things done. It's impossible to achieve full potential doing things by yourself. So this is really about relationship management. So the subjective part of my evaluation is really, how are you doing? Have you built relationships with key community members, city management, key providers, the regulators, legislators, you name it. That's how I'm evaluated.
What are the major challenges of running a hospital in the North Country?
Well, recruitment and retention of high quality professionals who want to live in the North Country. And that's always a challenge, and that's not unique to the North Country. I think it's unique to rural, or common to rural America. There is an assumption that you can't get good help up here. This is the B team, if you will. I have not found that to be true. You just have to make sure that you find the best fit. There are great providers, great staff who want to live in a rural community and take advantage of all that these communities have to offer. You just got to take your time to find them and then retain them. Sometimes it takes a little bit because we don't have all the amenities necessarily you'd find downtown Boston or something like that, but there are different amenities.
Right.
So it's really about making sure we tweak the package that we're offering to find the right candidate and spend the time doing it once, as opposed to making promises, having disconnection, and then having this revolving door of in and out. This just timely, it's costly and so forth. It defeats morale too. That's number one. Number two is we don't have necessarily all the access to services that we would like to have and sometimes need. Because of that, there are other agencies that are struggling with that same thing. Behavioral health, substance abuse issues, again, pretty common to most cities, towns in rural America. We're struggled with them here in the North Country as well. On top of that, though, we also have the issue of transportation. I mean, this is a very large geographic place. The spots for points of care are quite a distance in many cases, and there are a lot of people who just can't get from point A to point B. We don't have mass transit. We don't have the opportunities for bus lines and so forth. So that becomes a pretty big issue for us. Beyond that, it's just managing the razor-thin margins that any small hospital is up against on a regular basis anyway.
Well, so speaking of razor-thin margins, most community hospitals have 50% or more of their revenues coming from government sources,
yes,
such as Medicare and Medicaid.
Yes.
What's the payer mix at AVH?
We're about the same. I mean, it's closer to 60+% of Medicare, Medicaid. Self-pay makes up a small portion. We have seen it's gotten better, honestly, with the ACA, the exchange products since 2014-15. We have seen a decrease in our bad debt, and that's great. So the exchange products have actually done what I think they intended to do, is reduce the burden of bad debt. Commercial payers are about similar to a lot of small hospitals in rural New England. But yeah, we're very dependent on the Medicare and Medicaid payer systems.
How does the payer mix affect your strategy?
Well, we have to make sure that we're maximizing our critical access hospital status, which means we've got to think about that cost report and allowable costs all the time. We have to think about serving the state and the federal government in terms of meeting their requirements and needs. We take part in as many of the projects and so forth that we possibly can to maximize the return there, to leverage the opportunities that they both have in place. demonstration projects like ACOs and so forth. I mean, we want to take part in that. And we have those payer mix because that's our population. So we wouldn't be serving our mission if we didn't take advantage of those things and actually deliver for those payers. So it changes our strategy somewhat because we have to be mindful of the fact that we are cost-based, and sometimes they don't reimburse as well as, the commercial insurances. So we have to, again, it forces us to be cost conscious while maintaining the high standards of quality that CMS requires. So we have to do better with less money, and that's just pure and simple.
What would you say are the skills, competences, and abilities necessary to become the president of an organization like Androscoggin Valley Hospital?
I think first and foremost is relationship management. Just being able to work with multiple audiences, multiple people, clinicians, providers, layperson, board members, the community, technical staff, you name it. It's really about facilitation of all these parties and their expertise for the good of a common goal. I think being inspirational, so having fairly decent communication skills to get people to actually follow your vision is pretty important. But primarily it is about relationship management, I believe. You got to know what you're talking about at least as well. So there's some level of aptitude and intelligence is required. And I pride myself on having a great memory. I can remember, a lot of things, numbers and plans and so forth. You got to be able to quickly call upon experiences and apply them. I think there's a definite advantage in dealing with abstracts and what I kind of call spherical thinking. It's about interrelationships between, we're talking about this over here, but remember last week we were talking about this over here. Maybe if we do this instead of just this, we can do both. So it's really about the interconnectivity of problem solutions, ideas, concepts, and so forth. That's what I find very
something you
helpful.
mentioned you had kind of been fascinated by all the way back to your training.
A synergistic approach to looking at solutions.
Okay. How did your experiences as the Chief Operating Officer at Sebastopol Valley Hospital prepare you for this role?
Very much so. The CEO, actually all of my CEOs at Sebastopol, I had 3 different CEOs there, were very much, very supportive leaders in terms of my own career development and enhancement. So they gave me a lot of opportunity to help staff or support their functions as CEO. So I was exposed to staffing a board committee, supporting the development of our final reports and so forth. And so it really prepared me for the concept and the role of the chief executive beyond just, the day-to-day operations. However, the importance of understanding the day-to-day operations of running a hospital is critical, I believe, in order to actually lead it from the chief executive level. You got to understand what's going on and what the impact potential of any decision or strategy or direction that you might take the organization in will have on the day-to-day operations, because that's where the rubber meets the road. That's where we actually take care of patients and actually do the billing and keep the revenue cycle flowing. So it was critical to understand the inner workings before I could theoretically effectively lead an organization through any kind of transformation.
You had several years of experience, as you were saying, in the senior executive roles. Mm-hmm. You are now the president of a hospital, and you've been in that role for about 8 months now?
8 months, yes. And it seems like about 10 minutes, so I think that's a good sign.
What surprised you most about actually taking on the role?
This was the hardest question I saw there. What surprised me the most? I think I've always had that sense of humility, the sense of, this is such an important responsibility. And many times consciously on the drive in to work, I will say, please, Lord, help me make the best decisions today, because there are 320 families depending on what we do. And, in terms of just being good financial stewards of this organization means supporting all these families of the people who work here. So that's, humbling. And I walk in not only proud to have that responsibility, but humbled by it as well. So what has surprised me most, I guess, is the sheer immensity of that responsibility when the buck stops here. Ultimately, I do have the board, and I leverage the board to my advantage, honestly, to say, it's never just me making a decision. I leverage my team. They're amazing people. They're incredibly talented and intelligent, and together we make the best decisions. So I know I have the support, and I believe when I take something to the board or Warren, this has been vetted. This is the best idea we can come up with. Based on this talent pool and a brain trust we have, it's probably going to work. So I'm comfortable there. But what's surprising is the responsibility, the accountability is still mine. At the end of the day, I need to be able to stand up, and I have, on occasions already, that I own it. Regardless of where it happened, when it happened, it's my responsibility. Even if I didn't make the decision, I'm responsible for it. That's incredibly humbling, even more so than I thought. Before, when I was helping facilitate a decision as COO, advising the CEO or saying, I think we ought to do this, and here's what could happen, might happen, did happen, or whatever, it still was their responsibility. Now it's mine. On the upside, again, I do have all kinds of resources I bounce ideas on. Warren is a very collaborative leader as well, and I've contacted him and said, let me bounce this off you. What would you do? And I still have my father, honestly, who's now retired, but he was a CEO for 27 years. So I regularly still call him and go, hey, what do you think about this? Now, I may not always take everybody's advice, but at least I have those opportunities to use people as a sounding board and get some perspective. I'm a life learner. I think, again, if I ever assume that I know all the answers, it's time to stop. There's always something new, never a dull moment, never the same day twice. Again, I'm learning every day. So that was, I think, was the most surprising, is how important it really is to be willing to stand up and say, okay, it's on me.
As the president, what keeps you up at night? So you're laying in bed and you're staring at the ceiling. What are you thinking about?
If it's not usual, okay, where's the margin this month, or how am I going to take care of that? It's really about making sure that we're doing the best in the eyes of the community, the patients. Have we made a decision? And it varies, from night to night. Many nights, I'll be honest with you, I sleep pretty well. We're doing okay.
Well, that's good.
But usually, and I thought about this as well, the theme here is really, was there something we could have done differently or better in the eyes of the patient? Even a good decision, a good outcome, what could we have done better? That's what keeps me up at night. We need to have a strong financial position. Sometimes there are tight months and so forth. I'm glad to say right now we've been doing well. As far as I'm concerned, I'll do everything in my power to make sure we keep doing well and running in the black. That helps. So it's really about how can we make sure that we deliver the highest quality that these patients deserve.
Let's transition, talk a little bit about leadership. What would you say is your leadership philosophy?
I consider myself a servant leader. I'm here to, support the people who take care of the patients, run the business, do the billing, you name it, run the processes that we put in place. Take your traditional org chart, the diagram, the pyramid, flip it on its head, and that's we're here to support the people at the front lines. And I really believe that. That's my job, is to do nothing more than make sure that we create and foster an environment where people can meet their true potential.
What would you say are the characteristics and behaviors of a good leader? And how do you aspire to those yourself?
I think the ability to listen, the ability to recognize one's own limits and amalgamate great ideas from multiple resources before making a decision or taking an action, and considering the impact of those actions prior to execution without being paralyzed by analysis, being willing to take responsibility for the outcomes, deal with the consequences, the courage of your convictions, if you will, but also the willingness to make yourself vulnerable and recruit first, and then rely on the talent and the expertise that you surround yourself with. Recognizing the ability, or recognizing how best to build the team. You don't want just a team of homogeneous kind of styles or approaches or whatever. Actually, one of my favorite leadership books was Lincoln on Leadership.
Okay.
And President Lincoln actually populated his cabinet after he was elected president with some of his adversaries. And really, it was to force the conversation about different perspectives, and maybe to, again, in the interest of the country at the time, to make the best decisions. if it was just my way or the highway, I mean, you're going to miss something. And so he consciously populated his cabinet of advisors with his opponents. And people thought he was crazy at the time, but at the end of the day, it was really about making sure you didn't miss something. Well, that's a talent as well, making sure you populate your leadership structure around you with complementary styles and expertise and so forth, so the team is more powerful than any one.
Can you give an example of a difficult leadership lesson maybe you had to learn the hard way?
Sure. So one of the challenges of being a leader at this level, because usually people who aspire and achieve this level are pretty confident people, and they're problem solvers to begin with, and somewhat impatient. There's a degree of impatience there, and that's not a bad thing for an administrator, and a desire to do well and to move forward quickly and just keep moving on, solve the next problem, bring it on. Letting people make their own mistakes and learn from them is difficult. And that was one of the lessons I have to learn here. It was one of my colleagues who made the transition from COO to CEO a few years ahead of me. I tapped him for some insight and said, so what is the number one thing you've got to learn to do well when transitioning from operations to the chief executive role? And he shared with me, you got to watch out for this. Don't solve all the problems yourself. Let people learn from their experiences and mistakes, even though you know it's a mistake. You got to make sure it doesn't negatively impact the organization. You still have the ability to veto or stop the process, but you got to let them learn, and you can't tell them they have to know it. They have to learn it themselves. That's difficult, and I have learned that already. I've taken that into account and have had people, almost go down a path, and I continually just ask them the questions and try and draw out it and so forth, and then maybe do some of the things, and they start to realize the error or the issue the unanticipated issue it caused that I anticipated, but I can't just tell them no. That's, they're not growing anybody that way. That's difficult, and that was probably the most challenging part to me, is to let go of the desire to say, no, let's just do it the right way. I know it's the right way. I know you'll know it's the right way eventually, but no, to let them do it their way. The advantage also up in there is maybe they're going to do it a little differently than I may have assumed, and it was the right way, and there is an opportunity in there. So there's an advantage to that. At the very least, a couple of times that's actually happened where maybe I understood what somebody was going to do. They did it, and I was thinking, okay, I'm going to have this, what did we learn from this kind of conversation? But instead it was like, oh, that aspect I hadn't considered, so it actually works really well. And frankly, great, let's go forward. So it has worked out favorably, but there's at least one example I can think of where, we almost got to the point where we were pulling the trigger on something, and I knew it was going to be a bad situation if we pulled the trigger, but I needed my senior director to know that herself.
Yeah.
So I let it get to that point, and she stopped and came into my office and says, you know what, I think I've rethought this, and after thinking this all the way through, so I exhaled and said, great, glad, let's go in this direction instead. But that was probably the most challenging, because I want to get this done, and let's move on to the next problem and keep moving. But part of my job also is to grow the next level and develop and mentor people, and that's what I really enjoy. But there's some risk inherent in letting people on their own, but there's also great value in that.
So speaking of maybe mistakes, in your experience, where do junior leaders make mistakes? Do you see a pattern?
Yeah, historically it's usually just comes with the lack of experience and wisdom of especially ambitious folks, and I applaud ambition, great. As much experience as you can gain as fast as possible, that's great for people who would aspire to this level. It's really about the lack of knowing limits, or truly understanding that there's things you may not know. So I always want to recognize, I'm sure there are things I don't yet know I don't know. And that's what I see as kind of a basic pattern, is they think they know, okay, what's going on, but there may be nuances or aspects of something they just haven't been exposed to before, and so jumping forward very quickly that might lead somebody in the wrong direction. You only gain with that experience. So I think that's pretty natural. It's a natural evolution of the growth of wisdom, frankly.
What leadership advice do you most often give junior leaders?
Take the time to vet the idea through your counterparts, peers, and colleagues. I mean, learn from other people's experiences. You don't have to do this on your own. Delegate the authority to actually execute it so that you don't have to do it on your own. That's most of the time. You can get a lot more done through other people than doing it all yourself. But making sure it's the right thing to do. There's an amazing group of talent around New Hampshire, around the country, that are willing to offer advice and share their experiences and so forth. All you got to do is take the time to tap into it. I've found, I believe personally, that it's the stronger person who's willing to say, I don't know, I need help, than the person who says, I don't need help, and then makes mistakes, or limits their ability to achieve the best outcome.
Did you have a mentor early in your career?
Absolutely. Number of them.
Mentors?
Actually, yeah, mentors.
Well, how did that person or people help you develop as a leader?
Well, again, my father was one. I mean, I watched him, how he behaved. There's just the sense of values that he, taught me as a child. I mean, that's where it originated. But then watching him as a senior executive and a CEO of a hospital, it helped me recognize the importance of doing the right thing for the patients first. Everything else was secondary to that. You had to figure out how to manage the rest of it, but it was really about the commitment to the mission. I had a number of other mentors. I mentioned Jack May, who really taught me about, okay, how do you manage, work with a board? How do you work with a system? How do you work a room? He was a great politician. I mean, he could really, he was always smiling and always making friends. And how do you manage relationships, build and manage relationships? I had another gentleman, Ken Hughes, was a mentor of mine, a formal mentor of mine at the EMHS days. And he just taught me a lot of the basics of, okay, here's senior executive level stuff you got to be aware of, thinking about managing politics and thinking about multiple aspects of any problem or solution and impact analysis and so forth. So, but they all influence me in different ways. Now, I always observe everybody I work with or for as well. And what I try to do is, analyze and recognize, okay, here's something I want to emulate. And as important as, wow, I don't want to repeat that behavior. Here's the stuff I wouldn't want to do or be known for. So I basically, everybody I've ever worked for, I've learned from. And I try to do the same for folks that work for me too.
So my next question was, do you mentor other leaders now?
Yes.
And what do you get out of being a mentor?
Well, actually, it's the pride. I mean, some of them, when I'm asked often in an interview, what's your proudest accomplishment? It's the people. It's watching people achieve more than they thought they could. And knowing that I somehow contributed to doing that, to calling out that talent that was inherently in there and enabling it to come forth and flourish. That's the proudest moments I have is watching somebody maybe go from a director to a senior director or to an executive level or achieve something they wanted to achieve, even if they didn't believe themselves that they were capable of doing it, just by asking questions and leading them to solutions, providing them resources and helping guide them along the way. That's my favorite part.
Are you mentoring anyone outside of AVH now?
Not formally currently, no, but I have many times, as part of my role in the college and as a fellow in the American College of Healthcare Executives. I've taken on mentor projects as well, but internally, I've got a few relatively new senior directors that I'm mentoring directly and growing them, because again, I think part of our obligation as healthcare leaders is to ensure the next generation of leadership.
So you mentioned the American College of Healthcare Executives.
Yes.
That's a professional organization.
Yes.
For healthcare executives, obviously. How has your membership in that organization been significant to you as a professional?
It's a great networking resource. Attending the clusters or attending the sessions, and then the regional chapter, the Northern New England Association of Healthcare Executives, is a great way to just connect with other people in a similar role, it's how we tap into the talent around the region and say, oh, have you ever dealt with this? What would you do in this case? What are some ideas? It's how we share innovations and best practices. That networking is probably the most substantially important. Beyond that, it's the education. I mean, now as a fellow, I have to keep my certification up, and that's a requirement, but it's also, again, I enjoy the lifelong learning, going to hear from the expert speakers and so forth about topics that the college provides, reasonably priced and available. So it forces that, but also it is an opportunity to continue to learn. So that's why I like the college very much. Being a member of the college also requires adherence to a set of ethics, and frankly, I live by them. I mean, I think I need to demonstrate them as well. And it allows me that kind of structure that I can always depend on. If I'm thinking about how do I make a certain decision, well, let's pull out the college's code of ethics, and they're, entrenched in my values alone. But, you can read these things and be guided a little bit. And the college provides that source of resource from across the country. Some of the best minds in our industry put these together and refine them and contemporize them every year. So it's an amazing resource.
If you had to pick one book for an early careerist healthcare administrator to read, what would you recommend?
Well, there are probably two.
Okay.
If I'm not sure I could pick one. Okay. One is The Servant.
Servant Leadership?
The Servant, yeah, by James Hunter.
Oh, The Servant.
The Servant.
Okay.
Yep. It's a parable, and Jim Hunter wrote it, so it's a fairly easy read, but it really talks about this concept of servant leadership, and it makes you stop and think about your own style and what you're in leadership for. So that's definitely one. The other one, honestly, I really like a lot is Fred Lee's If Disney Ran Your Hospital, and just one of those books that makes you stop and think about what are we really chasing, why are we doing this, and how do we get to the results we want. It's hard to argue that Disney knows what it's doing in terms of managing an experience. So this is really about pulling that all together, but tying it to the embedded values within healthcare as an industry, and getting people to do the right things for the right reason because they believe it's the right thing to do, not because they're in fear of non-compliance if they don't. You know what I mean? But Fred Lee does a great job of talking about things like compassion and so forth in that book. So I'd highly recommend either or both of those books.
So, last question. Mm-hmm. What advice do you have for early careerists who are planning a career in healthcare administration?
Get plenty of sleep now. No, I'm just saying. I would think that they would be best served to build their network, build relationships, spend time shadowing people, get to know as many people in the healthcare organization, but also look inwardly and say, why are you doing this? What's important to you? What's motivating you to be a healthcare leader? These are not easy jobs, but it's some of the most rewarding, as I had hoped, most rewarding work you can ever imagine. I mean, being able to make a difference in people's lives daily is really important. It's a privilege to be able to take care of people when they're vulnerable, scared, hurt, sick, don't want the service you're providing. It's an honor to work with the talent, the physicians, the clinicians, the nurses who sacrifice so much of themselves to take care of the patients every day. Being the leader of an organization that allows that to happen is an incredibly rewarding job. So I would highly recommend that they make sure that that's what they are in this for. This is not prestigious, and you're never going to get rich doing this stuff. Some people do, but that's in a usually non-profit, small community hospitals. Mm-hmm. But it depends on how you determine wealth. If you want to go home at night feeling like you have made a difference, this is a great job. And as long as you're comfortable, with some stressful situations and dealing with dynamics. I mean, if you don't deal well with change, wrong industry. Go do something else. But if you do and are willing to stay committed to your core sense of values and the mission of the organization resonates with you, the vision of the organization you're inspired by, then go lead it. It's the best job on the planet as far as I'm concerned. I know it sounds a little cliche, but there is no better, more rewarding job than than being a part of taking care of people, making a difference in their lives.
Thank you so much for your time today. This has been great.
No problem. Thanks very much. I appreciate your time too.
You've been listening to the Health Leader Forge, a joint production of the College of Health and Human Services at the University of New Hampshire and the Northern New England Association of Healthcare Executives. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again in about 2 weeks.